of this, adding radiomics to our studies has really improved our interpretation of the image. So how does this apply to what I said in one-stop liver assessment? This is the ultrasound assessment in the clinic, where you can use all your ultrasound parameters, all your ultrasound techniques to come to a diagnosis in a one-stop clinic appointment for the patient and hand the patient forward to the next management pathway for better management overall. So what do we have at the moment? Well, we have the B mode in looking at the liver parenchyma, surface irregularity, and picking up focal lesions. We have color and spectral Doppler and microvascular imaging techniques. We use contrast-enhanced ultrasound for focal assessment of liver lesions and transit times, and also for Doppler rescue. Elastography, both point shear wave elastography and 2D shear wave elastography have been around for quite some time, but the newer kid on the block is fat quantification. And this is really a game changer for a lot of us that have been practicing ultrasound over the last 20 years. So this one-stop clinic can do nearly everything, but what we can't do at the moment is have an accurate estimation, a measurement of necroinflammation. And we don't have a non-invasive estimation of portal vein pressures. Now, both of these are really new kids on the block again, but these will be coming soon to make the entire examination all-encompassing, not requiring any other parameters other than ultrasound to make the diagnosis. But this is now becoming available on machines, and Samsung provides a total care solution from the early stage of MASL, the inflammatory changes, the fatty changes, to the post-operative follow-up. So we've got newer techniques coming up which assist you in making the B-mode interpretation a lot easier and quicker. There are new developments in looking at elastography and fat quantification, and there are also many new innovations coming through to help you with your contrast-enhanced ultrasound assessment of those focal lesions. And I will go through these in turn. A machine is only as good as its B-mode imaging. So without really top-class B-mode imaging, you struggle to make the initial interpretation and diagnosis. And we are used to seeing the normal liver, the geographical liver, the fatty liver, and we can pick up areas of fibrosis and cirrhosis quite reasonably on your B-mode ultrasound examination, particularly with light fibrosis, which may be used and assessed further with elastography. The focal liver lesions that we see include hemangiomas most commonly, but these are tending to become more and more atypical. You may see focal nodular hyperplasia or HCC from the B-mode imaging, but these will require further assessment, very often with CT or MR. But now contrast-enhanced ultrasound should help you to get to the final diagnosis and interpretation very rapidly. But what can help you here is that when you see subtle or lesions that are not so clearly seen on your B-mode ultrasound examination, live liver assist will help you find that lesion, highlight it for you, and allow you to make further imaging assessment and make further, maybe even contrast assessments of those lesions. So it's very useful for beginners because they may be concerned they miss a lesion without the experience, or even if you're an expert liver ultrasound doctor, you may overlook the more subtle lesions. And of course, this is very useful for patients, for doctors who are inexperienced but are using this to screen patients. So this is something that's available on the machines at the moment and aids you to make the diagnosis. But this goes further now, and the time-consuming aspects of the ultrasound examination include that stopping to make the measurements and labeling that area. So this program now, when you've got in view, it recognizes, for instance, that this is the right kidney or this is the spleen, and it automatically makes and records that measurement for you, adding to reducing that overall time that you're taking for the examination. So these are some of the B-mode aspects that are improving your workflow in your department. And remember still that quality of that B-mode is so important to your interpretation. Microvascular imaging has been around for some time, and this is a very sensitive imaging technique. But it is dependent on movement. So the less movement you have, the better you're getting your quantification and clarity of that vascularization around lesions. So you want to actually be able to look at the vascularization in organs that are not moving so much. So the testes, the lymph nodes, the thyroid, this is very good. But in the liver and the kidneys, you have to have patient cooperation to make sure that vascularity stays as it is and is visible and interpretable. And you can use it in the liver, but you need to encourage the patient to hold the breath. So a cooperative patient is always very useful. And in these two examples of an epithelioid HCC and a focal nodular hyperplasia and an atypical liver, shows you that you can get very clear vascular pictures of the lesions and looking at the internal structure. But you can see it's very movement dependent, and any improvement on this in your assessment of the underlying focal lesion will be really very beneficial to your interpretation, and also it will make the examination more speedy and efficient. So let's now look at contrast enhanced ultrasound. Again, contrast enhanced ultrasound is now probably in its 3rd decade of assessment, and it's also been very useful looking at focal liver lesions. But let me take you a step back, first of all, and you think, why should you be looking at focal liver lesions when you have your CT available? Now, there are very many reasons for this, not least, of course, that you're subjecting the patient to radiation, particularly if it's a benign lesion. And benign lesions are often those that are referred by the primary care physician as an incidental lesion that will probably, in 90% of the time, be benign. So if you can assess this adequately without subjecting the patient to radiation or that volume of iodinated contrast, and give a firm diagnosis of a benign lesion such as a hemangioma, this is an asset. But as a radiologist or as an imager, would you assess and report a CT these days without liver contrast? But that's what you're being asked to do in ultrasound. And would you report and assess an image produced by someone else in a snapshot of time, and you can watch these changes dynamically? So what you're really asking us to do on B-mode ultrasound is that you're going to compare the unenhanced B-mode ultrasound with the enhanced CT, and this is not a level playing field. What you should be doing is comparing the unenhanced ultrasound with the unenhanced CT, and you can see how much better you are at picking up that focal lesion on the unenhanced ultrasound than you are on CT. And then adding the contrast, you can watch that lesion dynamically, and here we go from 13 seconds when it's hyperenhancement to 5.5 minutes, and it's washing out in this HCC. So you have washout in this HCC that you can wait for and get the diagnosis. So it must improve your diagnostic capabilities. And look at this one. This is a B-mode image of a cirrhotic liver with ascites and a clear lesion seen. On the baseline pre-contrast, you don't see anything. The arterial phase, there's some faint enhancement, and the venous phase, you're struggling to see if there's washout or not. But the hyper-enhancement is so clear after 24 seconds on contrast-enhanced ultrasound that this is almost now pathognomonic for an HCC. Contrast-enhanced ultrasound is not in all the guidelines for the diagnosis of the HCC, but this is changing over time, and newer guidelines will incorporate contrast-enhanced ultrasound in their assessment of a focal liver lesion in the presence of cirrhosis. And then we have now the newer assessment of the CUS-LIRADS, which is the using contrast-enhanced ultrasound to look at these lesions seen in patients with cirrhosis to determine whether or not they're a HCC. And you can see from this aspect of the chart towards the right that if you've got a hyperenhancement in a lesion that's greater than 10 millimeters in the liver, it's going to be CUS-LIRADS 4 or CUS-LIRADS 5, which is an HCC. So it's very good at picking up those small lesions, and 10 millimeters is a small lesion to see the hyperenhancement. And then you can watch for the mild or late washout, but it's not always necessarily something that you're going to see in the HCC. And this is a large prospective multi-center trial looking at the use of contrast in HCC with the gold standard, either MR, CT, or biopsy. And this showed, and this is a large number of nodules, 545 nodules in several different countries, and they actually showed, or we showed, that HCC has a positive predictive value with contrast-enhanced ultrasound of 97.3%, and 100% specific for the diagnosis of non-malignant liver nodules. And this is what's important. It's actually teasing out those patients that don't need any further follow-up. So this is not something we would recommend. But it's not just those malignant lesions that need contrast-enhanced ultrasound, it's those benign lesions. So all of these lesions here have been referred by the primary healthcare physician, and they all are the same diagnosis. They're all the same diagnosis because on the background of the fatty liver, your hemangioma may look different. But just by adding contrast-enhanced ultrasound at this stage, it's almost pathognomonic after 13 seconds to see that globular enhancement and the infilling. So you have saved downstream costs in this patient. And this is just another example that's been was on my list only this week, where there's a mixed echogenic area, echogenic liver, and pockets of cystic change. And this is an atypical hemangioma in the liver, and you can see on the CT examination there is some enhancement in the arterial phase, and maybe some washout later on, or iso-enhancement with the liver. But at 4 minutes on the contrast-enhanced ultrasound, you can see those areas within that more solid component not washing out at all. In fact, staying brighter than the background parenchyma of the liver. And this is, in fact, an atypical hemangioma because you're seeing this area here demonstrating that globular enhancement and infilling of that abnormality. This lady couldn't go into an MR because she had a metallic contraindication, but the ultrasound examination is pathognomonic. There's no further need for imaging, so this is where it's very useful. But notice there's a lot of movement here, and this may detract from the actual image itself. So what about in children? Now in children, this is even more important to get the diagnosis without subjecting these children to further imaging with CT or MRI, which involves sedation, gadolinium, or contrast, all of the things that you don't really want to be giving to the children. But this is clearly an FNH with that area of star-like spoke wheel and hyper-enhancement. But again, there's movement here. You want to improve that. So can we improve that? Yes. The breakthrough technology that's coming through is the micro-movement compensation. And you can use this to actually improve and track your image so that you're watching it at all times to go through to form your imaging. So this is now pixel-wise correction, and this really is very useful for when you have that movement or the patient cannot control the movement and you're watching it. So most of you use vessel max, which is a summation of the imaging on just normal conventional contrast-enhanced ultrasound, but you can see how that little bit of movement detracts from that image. But when you've got your microvascular CUS imaging, with that tracking control, you can see how much better that imaging and the look at the vascularity of that tumor has improved considerably. But you can go even further. You can bring this in and use microvascular imaging combined with contrast-enhanced ultrasound, and you can actually then look at the time of arrival of the contrast as it comes, and color-coded appropriately. So you've got compensation of movement, you've got microvascular imaging, and you've got contrast there, and you've got time of arrival. But you can also then start using it in high resolution. Some people call this super resolution, but super resolution is slightly different, but this is high resolution imaging. And you can see for this that it's in real time with compensation for movement, and you're getting such beautiful characterization and movement of those vessels, which makes your diagnosis so much easier. And you don't need to ask the patient to breath hold to get these images. So you've got the microvascular imaging with contrast-enhanced ultrasound, and you've got that time of arrival in the patient. Not only does it give you beautiful images, but it gives you better interpretation, quicker than you would have ordinarily. Perhaps in this sort of lesion you may not have seen everything and you require a second injection. So again, workflow has improved. So how does this all apply to you? Well, you've got your one-stop liver clinic, which I showed you at the very beginning, and you've seen also the lesions that are atypical. So in a patient that's referred from your primary healthcare physician, and you have a focal low reflective lesion in the high reflective liver, you're not sure whether this is an atypical hemangioma, which hemangioma will be the most common abnormality, but it doesn't conform with your conventional teaching of being echogenic. So this is all going to change over time. So currently, with our technology that we have available, we use MVI, which shows the globular changes around the periphery. Adding contrast enhanced ultrasound then shows you the globular enhancement around the periphery and the infilling. And then we have an atypical hemangioma in a fatty liver, and at the same time we can quantify the fatty change in the liver. So in this instance, it's 21.3%, so it's a moderately fatty liver with an atypical hemangioma. This is something in Western countries that we are seeing more and more because of the high prevalence of fatty change in the liver, and we are also seeing it in children. We see a lot of children now with small hemangiomas or are no longer echogenic but echo poor, and it's not appropriate to subject the children to further investigation with CT and MR when nearly all of these lesions are going to be benign. Here's another one. This is again a low reflective lesion in again a high echogenic liver, which is a fatty liver, and it's atypical. The color Doppler flow doesn't show you anything, but when you look at the contrast enhanced ultrasound, it's hyper enhancing. This is towards the end of the examination, and you're using the burst mode, bubble bursting, and you're watching reaccumulation of the bubbles within those lesions, and you can see on that burst phase the reaccumulation in an arterial from the center of that lesion. So this is a small lesion within this liver, but it's characteristically a focal area of focal nodular hyperplasia. We often use the MVI on these patients, and quite often the MVI is very characteristic of a spoke wheel formation and a focal nodular hyperplasia, and this is where movement control will also be beneficial. So here we have a atypical FNH in a fatty liver, and again you quantify the fat and you make the diagnosis. So you can see from what I've shown you today the multi-parametric ultrasound imaging of all the different parameters that you have on the ultrasound machine, from fatty change to elastography, and the rapidity that you can do these measurements, particularly now with USFF and the fat quantification in percentage. You have a meaningful parameter which you can relate to your patient and they will understand. So we only lack one or two more things to make it all encompassing, but the fact now that we can use contrast enhanced ultrasound so very much better than we could do before, giving such finer detail with the high resolution imaging and the motion compensation and time of arrival, just makes the overall examination much quicker, more efficient, and you get to your diagnosis really very quickly. Thank you very much.
Thank you, Dr. Postin, for excellent lecture. So now we have roughly 10 minutes for Q&A. And are there any questions or comments? I know I can see many of excellent ultrasound specialists. Dr. Please.
Young Choi from Trung-An University Hospital. Several questions for Dr. Lee. You mentioned several technical improvements of R20 as compared with the previous RS-85. So among them, what do you think is the best improvement for the diagnosis of chronic liver disease, including fibrosis, steatosis? I hope probably inflammation.
Thank you for the important question. Actually, I think that the biggest improvement on R20 platform is improvement on B-mode image quality. That's the fundamental aspect of our ultrasound examination. And also, as I illustrated during my lecture, there are very good PET quantification tools, especially using deep learning model. Actually, the issue is whether the AI model will work for multi-ethnic groups, because most the studies are done in single country and mainly in a few centers. But this study for development of a deep USF, we collected the data more than 12 centers from multi-continents. So regardless of body habitus and ethnic group, we found that it works quite well. So for fat, it is already excellent. But as you mentioned, inflammation is the next step to detect MASH in an early stage. Once it developed the fibrosis, we can classify using easy Schwab elastography regarding fibrosis staging reliably. But in terms of detection of inflammation, as of now, only two or three ultrasound vendors provide a tool to multi-frequency Schwab elastography on ultrasound platform. The basic principle is dispersion slope imaging technique. But the problem is, in order to make dispersion slope imaging reliable, we need to have a very high quality push pulse in order to create reasonably good RF, and we need to have a multi-frequency shear wave and then separately calculate the shear wave velocity in order to make a dispersion slope imaging. But with the current limitation in terms of strength of push pulse by FDA, all vendors use too low push pulse actually in order to make a strong RF phenomenon in human tissue. So many researchers try to raise the bar for the strength of push pulse, and Samsung actually tried to make a very sharp push pulse. If we can give short bursting push pulse, the ending result is wide frequency shear wave production. So maybe I expect in the near future, I know Samsung is working on development of dispersion slope imaging techniques with better transmission of push pulse and better estimation of shear wave velocity on different frequency shear waves. We can have a better result. Unfortunately, currently clinically available techniques are not so reliable based on my experience.
I agree. So actually, you mentioned the most important thing is B-mode image quality. So, and you mentioned the wide range of transducer. What about the frequency range?
So frequency, yes. As of now, the frequency range is 2 to 7. Compared to other major vendors, maybe it's not the widest one. They are developing third generation single crystal technology. That means they can use a higher voltage to produce ultrasound beams, and then the reliability of ultrasound beam production will be improved by 30% compared to the previous version. So I think the next, of course, we need to wait and see regarding the quality of next generation third crystal technology probe. But based on phantom experiments, it gives much better production of wide frequency ultrasound beams, including harmonic imaging technology.
Okay. Nowadays, a hot issue is the statosis. So you explained several technologies for PSI and UDFF, and also another.
Deep USFF is AI.
USS. How about the accuracy?
Accuracy is unreliably excellent. I'm not sure. So actually, we did a multi-center study. The study result is not yet published, so we need to go through the peer review process. But according to our internal analysis, the result is unbelievably good. So we don't know how AI works so nicely because we are not AI experts, but as of now, it works very well.
Actually, at least more than 90%.
More than AUC value is higher than 0.95, so higher than 90% accuracy.
Another thing is you mentioned live liver assist. What is it of the breakthrough of the patient through? If you use that one.
Actually, as of now, I don't have very reliable data regarding diagnostic performance. I have been using it for 2 months. In some cases, it works very well. In some cases, it couldn't detect very subtle lesions. So compared to expert radiologists, still it has inferiority in terms of detecting small subtle lesions. But for inexperienced users like a resident, it is definitely helpful. And also, even when I do the examination, maybe around the 11:30 a.m. At the end of my ultrasound session, my eyes are quite feel some fatigue. So maybe it gives some backup confidence regarding my detection capability.
Thank you. Congratulations.
Thank you very much. So are there any questions or comments? Okay. If not, in the interest of time, I'd like to finish this session. Once again, I'd like to thank Samsung for sponsoring this educational symposium. I hope you found today's symposium both informative and valuable for your clinical practice. Have a wonderful afternoon. Thank you very much. I have one appointment. Before the session ends, I'd like to remind you about the session evaluation. Session evaluation allow us to create better KCR next year, and you can have maybe random selection for receiving small prize.